So now we're going to spend some time talking about antibody-mediated immunity. We've been talking a little bit about immunoglobulins. Now we're going to understand what it is. I was explaining to you about different types of immunoglobulins. So an antibody, fancy word for it is immunoglobulins. That's the same thing. We don't put bags of antibodies in someone's arm, okay, in the hospital. We are, but it doesn't say antibodies on it. It says immunoglobulins. So that's a little sneaky thing with you going into a medical profession. You can see immunoglobulins, you know, like antibodies. Why they call it that? I don't know. It's Latin. Okay. So antibodies and immunoglobulins are the same exact things. Okay. I mean, globulin does mean protein, so it is a protein. So if you're low on proteins, you're not going to make antibodies, which means you're going to get sick, right? And our abbreviation is IG, and you'll see that quite often. Okay. The structure is, it looks like a letter Y. A lot of things in this course are a lot of letter Ys, whether it's the intrinsic and extrinsic pathways, going to a common pathway. When we talked about the platelet coagulate or platelet plug, and we were talking about the complement system, it's little Ys. Now we talked a little bit about antibodies when we talked about ABL blood grouping, right? So just a little bit, so you have an understanding of the concept of it. We're going to get on much deeper now. But the way it's set up is that it is a Y, all right, which is all protein, okay, made up of amino acids. And we have what we call over here two variable ends. This is a variable end. And over here is a constant. This part will be usually attached to some sort of macrophage or something like that, which we'll get into. So we have a constant region and the variable regions. And the variable regions always attach to antigens. So an antigen would be over here, an antigen would be over here. Antigens would never go where the constant area is. Constant area has different functions. All right, it can bind to a white blood cell. It can activate the complement system. Does a whole slew of different things. Now we have 5 different antibodies. Okay, 3 of them look like Ys. And they have different names to them. God bless you. This could either be immunoglobulin or we call them IG. So this could be IgG. This could be IgE or IgD. They only are one Y. IgA is what we call a dimer, and they kind of come together like this. And it's made up of 2 Y structures. This would be IgA. Then the big one that we have, and you can understand that as we get into this, they get heavier, and this is where we could actually, when you go into a laboratory, they could separate things by weight. There's also something that is a pentamer, which has 5 of them on here. And this is the big one. This is IgM. So we have IgG, IgA, IgM, IgE, IgD. You can use your mnemonic game. But that's not the order of abundancy or significance. It's just to help you that there's 5 different ones. Okay. So this is just showing you a picture of that. Now, it goes further. We could also call this variable region 1 and 2, and there's something called light chains and heavy chains. Don't worry about that for this course. Just understand the concept. There's a variable end, and there's a constant end, and it's made up of protein. Okay? These are the 5 different types that I just drew for you. IgG, IgD, IgE. Those are all just monomers, meaning just the one Y. IgA is made up of the two. We call that a dimer, di meaning two. And then the pentamer is going to be the IgM, which is the heaviest, of course. Okay? This again is just showing in a chart form. We're going to get into the functions in a moment. Okay? So, I have one slide for each one of these, and these are the things that you should know about them. IgG is what we consider our classic immunoglobulin, our classic antibody. Okay? It's the most abundant, and is 75% of antibodies in our body. It's a monomer. And this is most prominent when we're getting ready to prepare ourselves for our future, meaning our second immune response. Our first immune response, these are not made. These are only made when we've been exposed to something, and they start being made about 6 months later. Okay? For instance, if I was going to get the chickenpox for the first time, these are not going to be made. We're going to learn that IgM is being made. When we see that we have IgG, that is going to be a lot specifically for chickenpox, then I know that I've been exposed to it more than 6 months ago. A chronic infection. Something I've had. Does that make sense? It's not an acute infection, meaning like it just happened within 6 months, very recent. That's what you're going to see the difference with. We'll get back to that when we talk about IgM. IgG binds to the complement system, and it's going to amplify phagocytosis. It's going to be a significant opsonate. And IgG is the only antibody that crosses the placenta barrier. This is what's going to go to baby. Or the fetus is just not ready to make antibodies because their immune system is not working yet, right? So it's going to have to rely on mom to bring in antibodies from her to get into the fetus. The IgGs are responsible for that. Those are the only ones. But the best way to remember that is, if you know gestation means pregnancy, then just think of IgG for G for gestation. That'll help you with that. So this is going to protect for the fetus. It's going to protect the newborn up to 6 months after the baby's born. Does that make sense? Baby's born. It still needs to be able to build immunity. It doesn't have that. So it's going to rely on the antibodies that mom gave him or her 6 months after delivery. All right? Usually after 6 months, the baby can start making its own. But it has to rely on mom's immunity. So therefore, mom has to have a good immune system. Otherwise, the baby's at risk. If mom has HIV, baby's going to be at risk. All right? And this is what explains all those Rh reactions when we talked about erythroblastoma fetalis, right? The Rh, when we talked about RhoGAM and stuff. The antibodies, if the mother is sensitive to Rh from a prior pregnancy, she has antibodies to Rh. These are the antibodies, which is IgG, that can cross the placenta barrier and get into the baby and destroy the baby's red blood cells. IgA. IgA, about 15% of our antibodies. These are the dimers. These are the two Y's together, so they're heavier than IgG. And this is located in all mucous membranes. It's in our tears, it's in our saliva, respiratory tract, GI tract, vaginal mucosa. It's also in colostrum and milk. Do you know what colostrum is? Colostrum is when a mother delivers a baby, the first milk that comes out of the breast, usually for the first day or two, is very rich in protein, very rich in antibodies. We call it a special kind of milk called colostrum. Breast milk has the antibodies. This is the advantage of why a woman should breastfeed. I'm a big breastfeed advocate because there's so many things that are in there that the baby can't get elsewhere. Antibodies is one. Yes, the baby does have antibodies for 6 months for the IgG from the placenta, but we need a continuation of it just in case the baby doesn't make antibodies quick enough. So we could get those antibodies from the milk. What type of antibodies? IgA. Okay? Questions about that? The only antibodies that we found in milk is the IgA. Then we have IgM. This is the heaviest of all the antibodies. It's the pentamer. It has the 5 Ys, and it makes up for about 9% of all the antibodies. Although it has, as I showed you, the variables, let me just draw it really quickly. Because it's the way it's set up that, yes, the variable ends over here, there's 2, but because of the way the pentamer is, it's pretty tight, you can only fit 1 antigen here, 1 antigen here, 1 over here, 1 over here, 1 over here. You would think because there's 2 here, you would have 10 antigens going on here. But the way that it's constructed, you could only fit 5 antigens. This is our main antibody when we get first exposed to a certain antigen. Okay? It takes some time for us to build that up. That's why chickenpox, when you first get exposed to it, you get the manifestation all over your skin. Because it takes some time. It takes 2 to 3 weeks to really get your body's IgM up to par to defeat that virus. So if someone has, and now we're going to put this together, if someone has hepatitis, let's say hepatitis B, I would like to know, was he recently exposed to it, or has he had it for a number of years? What I would do is to do an analysis of his antibodies. I noticed that he has IgG antibodies for hepatitis B. That means he's had it longer than 6 months. He's a chronic carrier. He's had it for, I don't know how long, but I know for at least 6 months, and we call it by definition a chronic carrier. He's been exposed to it. Does that make sense?
I think that was specific for.
They have the analysis. You can actually weigh them down, and it's kind of like how can you tell if this fingerprint is this person's, or if this DNA is this person's? They actually can weigh them, and they can actually, because the variable n does change. So you can actually see what that's a fingerprint, basically, that only marks for hepatitis B antigens.
So the structure is the same, but the...
Correct, but the variable, because the word is variable, that changes with each antigen. The constant doesn't change at all. Does that make sense? Okay? And they could weigh those and see what's going on with that. So if someone has IgM for hepatitis B, I know he has an acute infection, meaning he's got it within the past 6 months. Because IgM disappears after 6 months because IgG takes over. All right? Hint, hint. Understand the concept of acute and chronic infections when dealing with IgM versus IgG. It's going to help you later on. And that's what they look for when you go for your blood test for MMR or, let's say, measles and mumps and stuff. They want to see if you are a recent carrier, or did you get the vaccine from before. You see what I'm saying? So they can actually test for those things. All right? An IgM binds to the complement system, acts as antigen binding receptors on the B cells, and this deals with the transfusion reactions in ABO blood group. Not the RH going into the baby, but when you put the wrong blood in someone's arm, this is the one that's going to be exposed. You would expect that too, because IgM is the first one to come to attack something. I'm using the word attack loosely because antibodies never attack, they mark, and I'll explain what those are to help them with the cellular system, with T cells and T cells. Then we have IgE, and this is the least abundant one. This is only like less than 1% in our body, and this one is responsible for building up our immune response to allergies and worms, which is very similar to eosinophils, if you remember. That's why this one's easy to remember. If you remember eosinophils deal with parasitic worms and allergies, then think of the E for eosinophils, and now you've got IgE. Okay? So this is prominent in allergies. Allergies is, we're going to get into hypersensitivity reactions later on, but that's a type 1. And it binds to eosinophils, basophils, mast cells, and creates a release for inflammatory responses. Okay? Then we have IgD. We know it exists, we just are unclear about what the purpose is over there. We know that they're present on all B cells except for plasma cells. We're unclear about what it actually does. Okay? And they're more prominent than IgE. Okay? So those are our 5 different antibodies. Questions about that? Okay? There's a little chart form you can do on there. All right. So what about the antibodies? What are they going to do? What are they going to target? Well, antibodies themselves, as I explained to you, they don't destroy the antigen. I use that word attack, and that's wrong. They don't attack. They're going to mark things, or they're going to do other things. They can inactivate things and tag them for destruction. All right? All antibodies form an antigen-antibody complex. And in certain diseases, these antibodies-antigen complexes can get rather big and clog up certain areas. They can start clogging up the kidney and stuff. Okay? You see this with lupus and other places. They shouldn't do that. We should be able to clean up the act once it's done. So what do? Their defense mechanisms, they're going to be doing a few different things. Neutralization, agglutination, precipitation, and complement fixation. What do those things mean? Okay. We could do neutralization. Antibodies can actually coat an antigen so much that that antigen won't affect something. It's basically taking, you know how babies, they have nails on them and you don't want them to scratch their face, so they put mittens on their hands so they don't scratch their face. That's what we're doing here. We're putting a coating on the on certain viruses and exotoxins from bacteria so that it doesn't affect our human tissue cells. It's not the best thing, but it's some deterrent, right? But we neutralize that bacteria, whichever. We could also agglutinate. And we talked about that when we dealt with the ABO blood grouping when we were having those reactions, right? It's going to agglutinate, like you saw on those little trays for ABO blood grouping. It forms a lattice there and creates a clumping. We also have precipitation. Sometimes what happens here is that certain bacteria, or antigen for that matter, is very soluble in the plasma, and the immune system really can't see it. It's kind of invisible. It's there, but it's soluble in the plasma, it's soluble in the water. So if we put a lot more antibodies to it, it precipitates it out. Makes it more of a solid so that the immune system can see it. We also have complement fixation, and that's going to be the main mechanism used against cellular antigens. All right, when I say cellular antigens, that could be like getting a foreign organ, like a kidney, all right, things like that. Antibodies bound to the cells, change the shape, all right, and also triggers the complement fixation to get this started, and also cell lysis. All right, when I say cellular antigens, remember, it's not just human tissues, it could be bacteria, that's cellular too. Then we could also have complement activation, and that's just going to enhance the inflammatory responses, okay? So we put this all together. Here's a little picture form showing these different things. All right. You have this antigen that's going to form this antigen-antibody complex. All right. We could either neutralize that particular bacteria by putting that little mitten on the baby's hand so it doesn't scratch itself. Okay. Agglutination, all those red blood cells agglutinate together, they clump together, which you saw in those wells. We could precipitate that particular thing, should it be soluble in the plasma, so we can precipitate it out so the immune system can see it better and then attack it. Or the complement, we're either going to do any parts of the complement, whether we're going to do phagocytosis, right, opsonization, we can do the inflammation area, we can enhance that, or we can enhance cell lysis. All right, so again, antibodies don't attack, they mark something, and they do these other things over here, but they're not going to attack per se, they're going to mark things. All right, questions about overall functions of the antibodies? All right. Now, making antibodies. The primary response, when a B cell is first activated by way of interleukins that come from the macrophage, when that happens, the B cell is going to proliferate, make more, that's what proliferation means, make more B cells. And these could either change into memory B cells, where we remember that actual antigen for future references, or it could turn into a plasma cell. And a plasma cell is this big antibody factory. It's going to make all these antibodies. Which ones? Well, at first it's going to be IgM. Later on it's going to make the other ones too. That's what happens to the primary response. Then the secondary is during a later exposure. You have the chickenpox for the first time, you got the first response. It takes some time for that to happen, 2 to 3 weeks. That's why you have that whole manifestation happen on your skin, because you can't fight it very fast. Okay, your immune system is building up. But the second time around, you get exposed to chickenpox and nothing shows up on your hands. That's because you already have an immune system to it. You have these memory B cells that remember exactly what antibodies and how much to do to defeat that particular virus. And it happens so fast on the second response that you don't get a manifestation. It happens in a matter of minutes to hours, as opposed to days to weeks. So the second response is much faster, and it's much stronger, the response. So let's look at this little chart over here. More about the gray area. What happens here, this is the response to the virus, and this is time. Our first response might take 2 to 3 weeks for that to happen, and you've got a little response that happens. You get the chickenpox over here, it's going to take some time, 2 to 3 weeks, for your body to get rid of it. Second time around, you get exposed to chickenpox. It happens much faster, the immune response. It's very short, and the response is very great. So great that you're not going to see anything. This is how vaccines work. Vaccines, and I don't want to teach you a lot of things about vaccines. You'll learn more about it in microbiology, but what they're giving you is a small, weak amount of that particular virus. Influenza virus. They're giving you a small amount, a weak amount. You can get sick from it. They're giving you a weak amount. They're giving you the actual virus. Does that make sense? Sometimes it's killed, sometimes it's not, which, again, I don't want to get into that. But you can get sick from that because they're giving you the virus. But a very small amount, a very weakened amount. We call it attenuated. So now you have the antigen. So your body sees that antigen and makes antibodies to it and destroys that virus right then and there. But it takes some time for that to happen. It's the first response to it. Now, should you get the influenza virus later on in your life, well, the second time around will happen much faster and much greater because you're immune to it. Now, the problem is, with, I'm using the example influenza virus, why should you get an influenza vaccine every year? Because there's different variants. Every year, the influenza virus mutates a little, and it's a different variant. So they got to see what the most common variant is of the next year, so they'll give it to you. Does that make sense? So that's why the vaccine, you always got to get a new vaccine each time. Again, that's more about microbiology. I don't want to spend too much time on that. Question on how vaccines work in chickenpox? Okay. I know this picture is pretty bad. You can't see it very well, but this is just showing you what's happening is that you are just building antibodies as you grow up. When you come out of your mother's womb, you have your mother's antibodies that are not going to last very long, but then every time that baby, child, toddler, teenager, adult gets exposed to something, it's building new antibodies. So you are just a big collection of antibodies when you get to the ripe age of death. And that's what it's just showing you here. You get exposed to an antigen, you have antibodies. You get exposed to a different antigen, you're going to have different antibodies, and so forth. The antibodies will always stay with you forever, so that you get exposed to things. Okay? Questions about that? So ways that you could acquire the immune system, all right, for the adaptive way. We could have something called, this is a little bit confusing, but when you look at it, it's like, I don't even know why it was confusing, because I have a few charts here. You could have naturally acquired immunity, and that could be active or passive. This is the immunity that you're building naturally. If it's active, it's that you have been exposed to the chickenpox out here, and your body's going to naturally make antibodies. It just happens naturally. It's active. It happens just the way it's supposed to. Passive, naturally passive acquired immunity is when the baby gets exposed to it. You see, the baby doesn't get exposed to the outside world. It's passively getting, because mom was exposed, and then mom's immunity goes to the baby. Does that make sense? So it's still natural, but the baby wasn't exposed to it. It was because mom was exposed to it. Does that make sense? Okay? Then we have artificially acquired immunity. And again, we have active versus passive. Active is just the way a vaccine works. This is artificial. We're going to artificially give you the antigen so that your body creates the antibodies to it. You weren't actively exposed to influenza virus. We're going to artificially give it to you. Does that make sense? And then you build immunity to that. Cool. Questions about that? All right. The passive are artificially passive, a little bit confusing, not so bad. We're just going to give you the antibodies, not the antigen. Now, the best way I could explain this is venom to a poisonous snake. That poison has antigens, and your body is going, you get a king cobra that bites you. Now you have antigens. Your body is going to take 2 to 3 weeks to build an immunity to it, but you'll be dead by then. Does that make sense? So what you've got to do is artificially, passively, somehow get antibodies that are already made to go inside your body. Does that make sense? And that's what the venomous serum is. They've actually created the antibodies from other people who've been exposed to that particular venom, and now they put it in a little vial of antibodies. So if you're in a zoo, working as a zookeeper or something, or if you're working with snakes in a university or whatever, and you're working with clean cobras, yes, those particular places will have anti-serums of those particular snakes, should you, God forbid, get bit by one of these snakes. So they're going to give you the anti-serum, which is going to be the antibodies. And then your body will react to that very quickly. You're bypassing your body to make those antibodies. It takes them long. Questions on that? All right. So this is just showing you in chart form natural active, natural active, natural passive, artificial active, artificial passive. You can do it that way, or you could also do it in this little flow chart. Same thing. Right. It's not too bad. I think you look this over for about 10 minutes and you'll understand those four concepts. Okay?